Good evening, everyone. Uh, so, topic for today is actually a follow-up of high-risk neonates. So, we all know that over the last few decades, the survival of the small and sick newborns has increased. But now, with the increasing survival, we are seeing a lot of these babies who are coming to us on follow-up that they are not doing that well as a normal child should do. Okay. So in today's world, it is very important to have a good follow-up of these high-risk units which we are discharging, because see, if we have treated the child and if we see the child on follow-up, uh, we will be the best person to judge how the baby is progressing rather than someone else, some other pediatrician to whom the child goes for follow-up. Okay. So it is very important. One of the important aspects of neonatal care in today's world is to have a good follow-up clinic. It has even got some medical legal implications. Okay, so it has to be done. A good follow-up has to be done for the benefit of the patients as well as ensure that we remain safe medico-legally. Many of the times it happens that when we discharge the child seems to be apparently healthy, but when they come for follow-up, they may show some other developmental abnormalities or maybe some problems with vision, hearing, or other problems. So in that scenario, it is very important that we have a regular follow-up with these neonates. Okay. So with this brief introduction, I'll move on to the starting of the talk. So for today's talk, the objectives would be that why should we follow up these high risk units? Why do we need a high risk follow up clinic in our unit? Second is that who are the babies who need to be followed up? Do we need to follow up all the babies who are delivered in our hospital? Third is how are we going to follow up, or what is the procedure, or what needs to be done when these babies come to our clinic for follow up? And lastly, when and how often do we need to follow them up? So, with these questions, I'll start the talk for today. Before I start the talk, there is a small disclaimer that whatever points I will be highlighting today, those are more specific or relevant to our setup. I mean, to the setup where I am working. Of course, all the setups are different, so there may be different challenges. There may be different resources available. So whatever I am talking today may not be relevant in some of these setups. But again, I mean, I have tried to focus today's talk so that it is helpful to our residents and so that we can at least ensure a good follow-up in our unit. Okay. Uh, so coming to the first part of the talk, that why do we need to follow up these high-risk newborns? Okay, because I mean, it has been quite some time that we have started follow program for our neonates discharged from our unit, and I often find that the residents who are posted in that area, they are many times not interested, and sometimes they feel that it is this thing relaxed posting. So I probably feel that many of the times this attitude is because they don't know how important the follow and why do we need to follow up these newborns. Okay, so as I told before, that over the past few decades, the survival of the small and sick newborns has increased drastically. And with the increased survival, there is an increased burden of children surviving with long term morbidities, including neurosensory impairments, developmental delays, and motor impairments. So this was a systematic review which was published in the year 2012, and they had seen or they had followed up a large number of babies in thousands and from different countries of the world, and this systematic review was published in Lancet. And what they found is that the incidence of neurodevelopmental sequelae after various neonatal morbidities. So, if a child, for all the patients who were admitted with sepsis, almost 40% of the babies who were followed up had some or the other problem. And for babies who were admitted in the NICU for meningitis, almost 42% of those babies had some or the other neurodevelopmental sequelae. When I talk about neurodevelopmental sequelae, it does not mean only cerebral palsy, or it does not mean only ROP. Many times these may have some cognitive impairment, some functional impairment. So when we follow these up, when we follow up these babies, only then we'll come to know what are the problems these babies are these surviving babies are facing outside. Okay, so babies who had HIE, 31% of them had some or the other neurodevelopmental sequelae. For babies who were born premature, again 31% of them had some neurodevelopmental sequelae, and those patients who had CMV infection, the incidence of neurodevelopmental sequelae was again 41%. Okay, and the common sequelae in this systematic review, the common sequelae they found in these high risk newborns was many of them they had learning difficulty, many of them they had developmental delay, some had cerebral palsy, and some had hearing or visual impairment. So many of the times when we think of bad outcomes following discharge from the NICU, the first thing which comes to our mind, or many times the only thing which comes to our mind, is cerebral palsy. But it is very important for us to know that it is not only the motor impairment. Many times these children who survive later may have some learning disabilities, may have some delayed development, delayed milestones in other domains also, not necessarily the motor domain. So again, this slide is very important, that again to stress why we need to have a good follow-up is because uh, whenever a child is born, so a newborn has a brain maturity only 25% that of an adult. So when a child is born, he is born with an immature brain. Now all the bad experiences the child has in the NICU plus the disease for which he or she has been admitted will have a negative impact on the developing brain. And the problem is, or the other part of the problem is that uh, if we don't identify these problems at an early stage, they will become, or they may lead to some permanent neurological sequelae. Okay, but the good part is that, as I told you, that the child's brain is only 25% developed. So rest of the development has to happen by the age of 2 years and 5 years, as is shown in this figure. So by the age of 5 years, almost 90% of our brain is mature, and somewhere around 75% is mature by the age of 2 years. So what it shows is that we still have a window of opportunity, because if there is something bad that has happened to the baby's brain in the initial period, there is still a window of opportunity that if we are to some extent able to provide some good care to the child, maybe we can alter the permanent neurological damage which may happen otherwise. Okay, so this is because of a very important concept of neuroplasticity. Neuroplasticity, it is actually the ability of the brain to make short term and long term connections to the strength and number of the synaptic connections in response to incoming stimulus. Okay, and this neuroplasticity, it is actually helpful because whenever a child has any neurological damage, say due to birth asphyxia or due to bilirubin encephalopathy, or maybe due to prematurity, it there is still a window of opportunity that if you provide positive stimulus, or if you provide uh, good stimulus to the child in the subsequent months, there is a chance that he or she may develop good neuronal connections, and the disability which the child ultimately lands up will be not so severe as it would have been otherwise. Okay, and this neuroplasticity is otherwise a lifelong property, but it is most prominent in the early years of life, because that is the period where rapid brain growth and synapses are getting formed, and rapid brain growth is happening. Okay, so this neuroplasticity, it actually provides us a window of opportunity that whatever damage has happened in the neonatal period or in the perinatal period, to some extent we can decrease the negative impact of it if we follow up these children early and we do some early interventions to prevent the neuro disabilities. Okay, so as I told you, that early identification and intervention during the early years of life, or during the initial years of life, will help to improve the long term outcomes and help to reduce the burden of disability. Okay, so we can ensure a good neurodevelopmental follow up only when we know that why it is important. Okay, so that is why I have stressed on these slides that first of all, the doctor who is sitting in the follow up clinic has to be aware that why he or she needs to sit there, and what is his role or what is his job there. Because I mean, until and unless we are motivated, we cannot motivate the parents to have a regular follow. Okay, so this was about why we need to have a high risk clinic. And if we have a well functioning high risk infant follow up clinic in our unit, so what are the possible benefits this clinic will have? First is that it will help to improve the guidelines and the care provided in the NICU, because see, when we see these babies in follow up, and when we see that, oh, this baby has some or the other neurodevelopmental delay, we can improve the care that we are providing inside the NICU, because we know that, okay, if we don't provide the care, proper care inside the NICU, he or she may become a child with developmental delay or a disability. Okay, so it will help to improve the care which is being provided inside the NICU. it will help us to provide education and information to the parents, because many times parents are actually laymen or lay persons. They are not able to identify or recognize the initial signs which a child is showing for developmental delay. Okay, and so it is very important on our part to educate and inform the parents that okay, there are some signs of developmental delay. Maybe when the child is 4 months, 6 months, 8 months of age, we as doctors sitting in the follow-up clinic will be able to identify okay that the child is lagging behind in some domains, but for parents the child would otherwise be healthy because he is taking feeds, he is playful and otherwise. Okay, so we as doctors can educate and inform the parents that okay, the child is showing some early signs of a developmental delay. Okay, third is that it will help us to identify early about the future developmental problems, and it will help to facilitate the research, because see, whatever interventions we are doing in NICU nowadays, all of you would have seen that all the guidelines which are coming or all the new therapies which are coming, they are focusing on the neurodevelopmental outcome. Okay, we have moved away from the time where we were focusing on improved survival. Now we are focusing on intact neurological survival. Okay, so all the research is now directed towards improving the neurodevelopmental outcome. So if we have good data in our follow-up clinic, we can have good research also, because nowadays the neurodevelopmental outcomes are considered the gold standard in most of the researches which are happening in the field of neonatal care. Okay, then coming to the second $1 million question, that once we know why we need to follow up these babies, the second $1 million question is who are these babies who need to be followed up. So the babies who need follow up, actually there is a long list. Just to mention it briefly, that first of all the babies who are having a birth weight of less than 2 kgs, they need to be followed up. Any baby with a gestational age of 37 weeks needs to have a follow up, even though the child may be otherwise well, not requiring any respiratory support, not having any sepsis, and the child's course was totally smooth. You didn't admit the child to NICU, but since he is a premature baby, he needs to have at least some follow up. Okay, and the smaller the baby, the more aggressive follow up needed. Okay, then a child with hypoglycemia, be it asymptomatic or symptomatic hypoglycemia, both the cases, the child needs to have a follow up. Then any baby who is requiring phototherapy or exchange transfusion, uh, any baby with sepsis requiring antibiotics, be it culture positive sepsis or just a clinical sepsis based on the clinical signs and symptoms. Then babies with neonatal seizures, babies with birth asphyxia with any grade of hypoxic ischemic encephalopathy, and babies with neonatal shock. Other than this, the other list would also include babies with PDA requiring a medical or surgical management for PDA, then babies requiring invasive or non-invasive respiratory support, babies with Doppler abnormalities in the antenatal period, uh, any infant who is born to a diabetic mother, infant who is born with severe fetal growth restriction, whenever there is a history of previous intrauterine death or stillbirth in a mother, or a child with intraventricular hemorrhage of any grade, or PVL, that is periventricular leukomalacia in the scans at of any grade. Okay, so roughly these are all the babies who definitely need a follow up. If it is difficult to remember such a big list, roughly I can say that any baby who enters your NICU for XYZ any reason, okay, if the child has just a simple jaundice, but he or she has needed phototherapy for that jaundice, even then you need to have a some degree of follow up, because some of these babies may show some developmental issues at a later age. Or a child who is just admitted for a simple perinatal depression requiring bag and mask but did not require any respiratory support, still the child needs to have a good follow up. Any child who is born to an infant of diabetic mother, or any child who is born IUGR, all these babies, they need some degree of follow up. Okay, so again, these are just this is just a list of the babies who need follow up. I'm not telling that all of them would require same degree of follow up. The level of follow up which we need to provide will be different for each baby. We'll discuss that in the subsequent slides. Then coming to the third part of the talk, that how do I follow up? Now we know that we need to follow up the babies. What is the importance of following these babies? Second part, who are the babies who need to be followed up? Then coming to the third part, that how do I do a follow up of these babies? Okay, or what needs to be done in the follow up? So first of all is we need to have a built or proper designated place. So like in our unit we have a designated high risk clinic, and that clinic is just opposite to the NICU. So the point to remember is that ideally the high risk clinic should be as near to the NICU as possible, because the parents, they remember that okay, this was the place where my baby was admitted. And so even at the time of discharge, we ask the parents to bring to the same place. Okay, so it is good to have a high risk clinic in the vicinity of the NICU if your infrastructure permits. Okay, luckily we had a room opposite to our NICU only, where we had space available to run the high risk clinic. Okay, so this is our high risk clinic. So it is just opposite to the NICU entry gate. And we should have fixed designated days for the high risk clinic: Monday, Wednesday, and Friday. In our unit, we have kept these 3 days every week. Okay, even other than these days, if a child comes for follow up, definitely you need to enter them in the register and you need to follow them up. But this is like, you should have fixed designated days. Sometimes it so happens that the parents, they come at their own convenience. Even that time we are supposed to see them. Then what is the procedure that needs to be followed when the child comes? So first of all, when the child, whenever a high risk baby, along with the parents, they come for follow up into the NICU, before, even before discharge, we should actually enroll them in the high risk clinic. Okay, so in our unit also, I ask the residents often that even before the baby is discharged from the NICU, on the day a decision for discharge has been made, based on the risk factors the child has had during the NICU course, the resident should enter the baby's name in the high risk clinic register. And at the time of discharge, it is ideal to give them the discharge card with a high risk clinic number. Okay, so we have a separate high risk clinic register. What I often ask the register, what I often ask our resident doctors is that at the time of discharge, once the consultant has made a decision in the morning rounds that okay, this child is getting discharged today, you know that okay, there are some risk factors this child had. So what you do is, based on the risk factors the child had, you go through it. If your child is fitting into the list of babies who need to be followed up or who need to be enrolled in the high risk clinic, you enter the baby's name and CR number, or the hospital ID number and phone number of the parents in the high risk clinic register, and you enter the high risk number which you are allotting to the child. Okay, and it has to be mentioned in the discharge summary also. So if you can see here, uh, this is the discharge pro forma from our unit, and there is a high risk clinic number which has been mentioned on the top of the discharge summary. Okay, so ideally for all the babies, I expect that this high risk clinic number should be mentioned if the child is fitting into any of the criterias for high risk clinic. Then not just labeling a child as high risk would be sufficient. Okay, we have moved away from it, and now what we are focusing is that based on the severity of the risk factors, we are actually trying to stratify the child as medium risk, low risk, or high risk. Okay, and so we need to identify the risk factors in a particular case, and based on the risk factors that are present, we actually have a system to classify them into a red, yellow, or green category using a color coded risk category division. Now, this color coded risk category system is based on the IAP consensus guidelines. So, this year only, in the year 2025, if you can read the date here, it is published in May 2025. So the Indian Academy of Pediatrics in the year 2025 has given guidelines, or has renewed the guidelines for develop for the follow up of these high risk newborns, and the IAP has actually come up with this color coded system. So this same system we are also trying to follow in our unit. What I ask the residents is that they should have this photos in their mobile phone, as well as a printout of this in the high risk clinic. So whenever a discharge is being done, or whenever a child is being discharged, based on the uh, risk factors which are present in the child, the resident needs to tick out to which category the child belongs. So if there is any of the red symptoms, or any of the problems the child has had which belongs to the red category, then the child ultimately lands up in the red category. If there are no features involving the red category, but there are some involving the green and some involving the yellow, you put the child in yellow only. And if there are no features involving the yellow or red, and the child is normal or otherwise normal, requiring a minimal O2 support, or clinical sepsis requiring only antibiotics, is fulfilling the criteria for green, then you put him in the green category. Okay, so at the time of discharge, what I ask the residents is that they should enter the high risk clinic number, as well as in the high risk register they need to mention the category or color coded category to which the child belongs. Okay, so this stratification, it actually helps to decide the frequency of follow-up. Why we should divide them into red, yellow, or green zone is because based on the zone in which they are following, in which they are falling, we'll decide how frequently we need to follow up, and also we can prognosticate the parents from the beginning about the problems which the child is expected to have, and what are the chances that a child will have some developmental delay. Okay, and as I told you that this color coded stratification has come in the recent IAP guidelines, so we try to follow these guidelines. Okay, and I mean, it is very easy to have this printout in our unit also, and I think all the residents also, they should have it in their phone. And so whenever they are preparing the discharge summary, so just they have to look for what are the risk factors this particular child had, and based on the category in which the child is falling, they should highlight the risk category in the discharge summary as well as in the high risk clinic register. Okay, and so these are the various categories. Okay, so there are two this thing tables for risk stratification, and based on the uh, findings in a particular case, we need to decide that which zone or which category the child is falling. Okay, so why is this risk stratification important? Because see, we have a study from India only in the year, this study was done, I think, in the year 2016, and by Dr. Naveen Jain and his team in Trivandrum. And they have told that if we use this risk stratification score, like the one which we are using, that if we stratify them into severe risk or high risk, moderate risk, and low risk, so using this risk stratification score, we can predict the neurodevelopmental outcomes better. Okay, so I think we have sufficient evidence that we should use this risk stratification system. Okay, and it is easy also to follow. Now, once the child has been discharged, and you have mentioned the high risk clinic number, at the time of discharge, we also need, based on the category in which the child is following, we will ask them to come for follow up on a particular day. So, if the child is falling in the red category, we usually ask them to come for follow up on the third day itself. If the child is falling into a green zone, then maybe you can ask them to come for follow up after a week or so. Okay, so based on the category in which they are falling, we will ask them to come for follow up. When they come for follow up, first thing the child, or as soon as the parents or relatives they come to our unit, the first thing to do is that they have to get themselves again registered. Okay, and so there is one person who is sitting on the outside. So there is one nurse who is sitting on the outside of this high risk clinic, and what she will do is she will enter all the baby details when they come for visit in the register, and then they will send the child to the doctor. Once the child enters the high risk clinic, the first thing the resident doctor has to do is that they have to start filling the high risk proforma and the first visit only. Okay, and so this is what our high risk proforma looks like. It is actually a simplified version, and there are many other things which actually should be included, but because our high risk clinic is not very well developed now, maybe it will develop in the next few years or months to come. So as of now, I have prepared a simplified proforma of 3 to 4 pages. So the first page looks like this. So whenever the child comes, you need to enter the high risk clinic number in this proforma. Then you need to enter the baby's name, mother's name, gender, and what is the age of the parents, and what is the address and phone number, what was the birth weight, gestational age, whether the child was SGA or LGA, and what was the length and head circumference at birth. So all these details we have in the discharge summary, but why we need to enter is because high risk clinic will have a separate record, and this proforma usually stays with our unit. Okay, what I want is that because sometimes it happens that the parents they misplace the discharge summary, or the discharge summary gets torn. Okay, so in that case, it is good if you have this sort of a proforma in your high risk clinic only, and whenever they come for follow up, you just update this chart. Okay, and so date of admission, discharge, what all were the problems, or what was the diagnosis at the time of admission, all this needs to be entered. Then the second page of this proforma has the date of visit. Okay, so this date, what is the date of the visit has to be mentioned here. Then what is the chronological age, what is the corrected age of the child. I'll come to these terminologies later in the talk. What is the weight of the child today, what is the head circumference, length, physical examination, if there are anything, if there is anything abnormal, you have to mention. What about the vision assessment and ROP screening, what about the hearing assessment of that child, any investigations you want to do. Sometimes when the premature babies they come for follow up, we want to screen them for osteopenia, we want to screen them for anemia. So any investigations if you want to do in that child, that has to be mentioned. And any specific treatment you are ordering in that child, that has to be mentioned. Along with that, it is very important that we mention the next day, next date when the parents need to come for follow up. Because what happens is, when you mention the next date of appointment, the staff who is sitting outside the high risk clinic, she will note the date on which she has to call the relatives again. Okay. And so when you mention the date of next appointment, she will make a note of that appointment date in her diary, and on that particular day she will call the parents again that you are supposed to come for follow up. Okay. So this is how we ensure that regular follow up is being done. Okay. And then there is a third page in the high risk proforma, where I have highlighted all the risk factors which that particular child has. So you just need to circle out the risk factors, or just need to highlight with a marker what are the risk factors that were present in this child. Okay. Then on the fourth page, you have to briefly do a neurological examination. Sometimes I mean, see, all these things are, I mean, there is nothing in this proforma which pediatricians or pediatric residents should not do. Everything is basic in this proforma. I have not included anything hi-fi, and it is very basic proforma. All these things like higher mental function assessment, cranial nerve examination, motor system, passive tone, and all the angles, active tone, power, superficial deep tendon reflexes, neonatal reflexes. All this is something that all the residents anyways need to do in their exam. So when these babies they come for follow up, take out time and try to do all these examinations. Because I mean, I have posted one single resident just for a follow up clinic, because I mean, you have time there. There are hardly 5 to 6 babies who come for follow up. So if you take time and do all these things and fill out the performance properly, it will be useful for you also in the long run. And also, when you are sitting in the follow up clinic, you can identify the developmental delays at an early stage. Okay. So then I use the terminologies in the previous this thing, this chronological age and corrected age. So what are these terminologies? Just for the residents to be more clear. Uh, so one there is one terminology called a chronological age. There is another terminology like gestational age. Third is a corrected age, and fourth is the post-menstrual age. Okay, so to clear out all the doubts, like what is it? Because these terminologies will again come in the in the further slides also. So gestational age is till the child is actually not born, he or she is inside the mother's womb. So it is the weeks since the first day of the LMP till the period at birth. Okay, so that will be the gestational age of the child. So if a child is born today at 31 weeks completed, so his gestational age would be 31 weeks. Okay, if a child is born at 34 weeks, then the gestational age would be 34 weeks. Then chronological age would be weeks since the birth. Okay, so now if the child was born at 28 weeks and he comes to you for reassessment at say 6 weeks. Okay, so his chronological age would be 6 weeks. That is number of weeks after the birth of the child. That will be the chronological age. And this chronological age plus the gestational age together will be called the post-menstrual age. Okay, so if a child is born at a gestational age of 28 weeks and he comes to you for follow up after 6 weeks, his chronological age would be 6 weeks, but his post menstrual age would be that gestational age, that is 28 weeks plus chronological age of 6 weeks, that is it will be 34 weeks. Okay, and then there is a terminology called the corrected age. Corrected age is actually number of weeks after the completed 40 weeks. Okay, so if a child has so in the previous example, like the baby who has come to us, who is born at 28 weeks and comes to us at 6 weeks, then his chronological age is 6 weeks only. Post menstrual age will be 34 weeks, but there is no concept of corrected age here because actually the child has not completed 40 weeks. Okay, the concept of corrected age comes only after the child has completed 40 weeks of post menstrual age. Okay, so once he completes the 40 weeks post menstrual age, once the 40 weeks are completed, how many weeks after that the child has passed, that will be his corrected age. So if a child who is born at say 28 weeks, he comes to you at 16 weeks. Now at 16 weeks his chronological age will be 16, his post menstrual age will be 44, but his corrected age will be 4 weeks, that is number of weeks after 40 completed weeks. Okay, because we expect the child to be born at 40. Now he for some reason he is born at 28 weeks, so that 12 weeks of prematurity we will exclude in the corrected age. So his corrected age will be uh, uh, 4 weeks only. Okay, this terminologies are very important to understand, because there are many things in the follow-up that need to be done as per the post-menstrual age. There are many things in the follow-up which need to be done as per the chronological age, and there are many things which need to be done at the corrected as per the corrected age. Okay, so these terminologies are very important for all of us to understand. Okay, then, so what needs to be done? So first of all, as soon as the relatives bring the baby to our high risk clinic, first thing is you start filling the high risk proforma. You highlight all the risk factors the child has had during the NICU stay. Then next thing what you need to do is you need to assess the feeding and nutritional status. This part is very important. That is why it has to be done first. Okay, you have to ensure the adequate feeding and volume the baby is getting. And if there is any lacunae you identify that okay, mother is not feeding the child properly, or there is some problem, then it has to be corrected at the earliest. You have to ensure that the child is getting micronutrient supplements, whatever iron, calcium, D3, whatever you have advised on the time of discharge. Have the habit of cross checking how much the parents are giving and whether they're actually giving or not. Okay, and you have to advise for complementary feeding at 6 months of corrected age. Okay, so this is a very important point to remember, that complementary feeding should be after 6 months of corrected age. So if a child is born at 28 weeks and he or she comes to your follow-up clinic at 6 months after his birth, okay, that time, see, 28 weeks was his actual birth. After 3 months only he will be completing 40 weeks. So when he comes to your clinic at 6 months of his chronological age, that is 6 months after his birth, many times I have seen that people advise them to start complementary feeding right from that point. No, it should only be started after 6 months of corrected age. So you have to correct for prematurity. A child who is born at 28 weeks, you can start complementary feeding after 3 months plus 6 months, that is after 9 months only. Till that time, ideally the child should be on breastfeeding. Yes, I understand it is very difficult sometimes, but the advice for complementary feeding should be after you correct for the prematurity. Okay, then coming to growth monitoring. So weight, length, and head circumference, it has to be checked, and it has to be plotted on the growth chart. In our clinic, what we use is Fenton's growth chart. Okay, recently the Fenton's growth chart have been updated, and the point to remember here is that Fenton's growth chart has markings only up to 50 weeks of gestation. Beyond 50 weeks of gestation, you should use the WHO growth charts. Okay, and early growth failure, if at all it is identified, it has to be corrected swiftly. Why? Because a child with high risk of neurodevelopmental impairment, if the nutrition is not good, definitely the child will have more problems. So nutrition is definitely something which is easily correctable, or which is preventable. Okay, so definitely whenever the child comes to you on follow-up, first thing you need to assess is that how much the child is feeding and whether he or she is getting adequate feeding. Second thing is you have to check the growth of the child, how well the child is growing. Okay, so you can see here the resident height, length, head circumference, and after checking that, it has to be plotted on the Fenton's growth chart. So as you can see here, the Fenton's growth chart can be used only up to 50 weeks. Once 50 weeks are completed, we should use the WHO charts. Okay, I have shown here only the weight for age charts. There are other charts also for length and head circumference. Okay, so appropriate charts should be used based on the gender and age of the child. Okay, then once you have checked the growth of the child, once you have registered the child in high risk clinic, you have started filling the proforma. Then you assess the feeding. Once you have assessed the feeding, you check the growth of the child. Once you have checked the growth of the child, next important thing which never should be missed is you have to focus on immunization, or you just have to inquire whether the immunization has been done or not. Okay, and again here immunization will be as per the chronological age. So a child who is born at 28 weeks, his immunization schedule will be as per his chronological age. That is, he should receive the first vaccines at the time of birth. Then 6 weeks, 10 weeks, 14 weeks should be as per his chronological age. Here you do not need to correct for prematurity. Okay, so immunization has to be as per the chronological age. And preferably the follow-up visits, whenever you are calling them for subsequent follow-up, try to combine the subsequent follow-up visits with the vaccination schedule. So if you know that okay, the child is say now 1 month, or say 30 days, 35 days, okay, and you are expecting them that at 45 days the child needs to have a vaccination, 6-week vaccination. So you arrange your follow-up such that on the same visit they can have a follow-up visit in the high risk clinic also, and on the same day they can get immunization also. So this prevents the number of visits, and it ensures that compliance to the follow-up schedule is good. Okay, so you try to club your follow-up visits with the immunization schedule. Okay, and then once you have checked the immunization, then you have to look for any other morbidities, medical morbidities the child is having, because there are a large number of morbidities. Like some babies may have prolonged jaundice, some may have GERD, some may have feeding difficulties, some may have recurrent respiratory tract infections. So you need to look for these babies when they are coming for follow-up, and any of these events, it needs to be documented in the high risk proforma, because each of these insults will again determine the long term outcome. So whatever you are seeing on the subsequent visits, that has to be highlighted in your proforma. Okay, so once you have checked, once you have done the medical management, once you have assessed the growth, and once you have assessed the nutrition, another important thing which needs to be evaluated is hearing. Unfortunately, in our clinic, I have seen very often that there is a OA, or autoacoustic emission, which has been done maybe on day 3 or day 4, and the child has been inside the NICU for 1 month, and after that there is no follow-up hearing evaluation done. So that is not right. Okay, and it is very important for us to know that many of these high risk newborns, they are at increased risk of moderate to profound hearing loss. So all the medicines which we are using in the NICU, many of them are actually ototoxic medications, be it amikacin, gentamicin, or your meropenem, colistin. All of them, they have some degree of ototoxicity. Plus, on top of it, your child is immature, or he or she has some insult to the developing brain. So that is why these babies are at a very high risk of hearing evaluation. The reason why our clinic we are not able to find out these babies is because we do not have a very good follow up, and many times we do not do a confirmatory test. So it is very important that whenever you see a high risk child in your clinic, you just have this thing, look at what is the hearing of the child, or how, or what is the status of screening. Okay, and hearing screening by OE. So many times in our unit also we rely only on autoacoustic emissions, but the thing to remember is that in these high risk newborns, the OE may not be reliable. Sometimes it may be falsely normal, and having an OE normal does not mean that the hearing is normal. Okay, so hearing assessment has to be done either by a BERA. BERA is actually a confirmatory thing. There is one more screening tool other than OE, which is AABR, that is Automated Auditory Brainstem Response. So that is also a screening tool. Unfortunately, at this point in our unit, we do not have this AABR, but maybe in the next few years, we will plan to have one in our unit. Okay, so this is one of the screening tools which should be there in the NICU, and all the high risk newborns on follow up, they should be screened using AABR, and if they are at very high risk, at least a BERA should be done. And all this should be done before the age of 3 months. So first screen whenever we are doing, it should be done beyond 34 weeks of postmenstrual age. So if a child is born at 28 weeks, there is no point of doing a hearing screening at 2 weeks or 3 weeks. It has to be done only when the child has completed 34 weeks of postmenstrual age. And remember the 136 rule. So what is this 136 rule? So any child, any high risk newborn who is admitted to your NICU, make sure that the first screen is done at the first month of life. You screen the child once. Once you have screened the child at first 1 month, up to the age of 3 months, you should get a confirmatory test in the form of BERA. Okay, and if there is any problem that has been identified in BERA or any of the confirmatory tests, then you should do an intervention to correct the hearing defect by the age of 6 months. Okay, beyond that, if you delay, it is going to have a long term impact on the child's overall development. His language, speech, everything would be delayed. Okay, so remember this 136 rule. It is very important that first screen uh, at 1 month, second is confirmation by 3 months, and then treatment has to be done. If at all needed, treatment should be done before 6 months. Okay, so this rule, 136 rule, is very important. So this is the screening chart. It actually, I have taken it from the AIMS protocol only, from the recent AIMS protocol. So as it has been shown here, that for low risk babies, it is okay if you screen them with an OA, but for high risk babies, you need to do both, an autoacoustic emission as well as automated auditory brainstem response. Okay, and both these will have a result in the form of pass or fail. So if the child is passing both these screening tests, then you can be doubly sure that okay, there is no hearing impairment. But if there is problem in any of these screening tests, that A, BR, and OE, any of them is showing a problem, you need to go for a BERA to confirm the diagnosis. Okay. And so the problem with BERA is that it is a confirmatory test, but the problem is that it will have many different ways, and sometimes it will be difficult to interpret. Okay, so that is why for interpreting a BERA, you need an audiologist or a specialist. But AABR, which I was talking about, so this is the AABR device, that is automated auditory brainstem response device. It is just like a phone or a telephone, and you need to place it on the baby's ear, and there is one more electrode that is placed on the scalp. Okay, and when you press the button, it will just show you the result in the form of pass or fail. So that does not require any audiologist to do. It can be done inside the NICU at the baby's bedside. Okay, but the device, you need to have a specialized device for it. There are many good NICUs who are doing this ABR inside the NICU or at the time of discharge and documenting it. At this point in our unit, we don't have it, but I mean, it is in plan to have it in the next few months or year. Okay. Then coming to another important aspect that needs to be taken care of is the assessment of vision. Now, very important thing, I request all the residents that vision assessment does not mean only ROP screening. There are in number of problems a baby with uh, baby at high risk will have. Okay, so your NICU graduates will have a lot of problems in the form of decreased visual acuity, or many of them may have myopia, many of them will have astigmatism, many of them will have squint. So all these developmental problems need to be assessed. And what we do is that, okay, we do an ROP. If they have told there is no ROP, we tell them okay, okay, everything is fine, and then there is no assessment. Ideally, these babies, they should have their first vision assessment at the age of 9 months, and it is advised that every 6 months at least they should meet an ophthalmologist till the first 6 years of life. Okay. So ROP screening, as I told, I mean, all of us know about the ROP screening, that it has to be done before discharge from the hospital, and it should be continued till 44 weeks of PMA or till your vascularization is complete. Frequent repeat screening after the initial screening should be as per the advice of the ophthalmologist. But in addition to ROP screening, what is our job? See, ROP screening, you just need to motivate the parents and send them to the ophthalmologist. Ophthalmologist will do. Our job is that other than the ROP screening, we need to ensure that you are sending these babies on follow-up to the ophthalmologist, just to have their visual acuity checked, whether their visual fixation and tracking is proper, whether they have squint or any other ocular abnormalities, whether there is red reflex that is present, and pupils are normal. So all these things also, they need to be assessed, and our job is that at least once in 6 months they go and see the ophthalmologist once. Okay. Then coming to the next step, that is neuroimaging. So for premature babies, ideally it is good to have a cranial ultrasound between 36 to 40 weeks. There are many centers who advise to do an MRI also at this age. But I mean, since we are a resource limited setting, we cannot have a general guideline that okay, for all the premature babies we'll have a MRI done. But at least you should have a neurosonogram at 36 to 40 weeks of post-menstrual age. So even this is something that is not happening in our unit. Okay, I mean, see, imagine a child who is born at 28 weeks of gestation. He has been discharged from our unit at say 36 weeks of post-menstrual age. When they come for follow-up after a month, uh, many of the times there is no ultrasound that is being ordered, but you should get an ultrasound done at 40 weeks to identify any changes of PVL which are seen. Okay. And if there are any abnormalities detected, like an IVH, PVL, or unexplained ventriculomegaly, then you need to go for an MRI to confirm the diagnosis. If you have a term child with perinatal asphyxia, then MRI brain should be considered if there is any of the following, that is seizures during the hospital stay, abnormal neurological examination at the time of discharge, encephalopathy at the time of discharge, or on follow up. So sometimes it so happens that the child has had birth asphyxia, and the child is a difficult child to feed. And even on follow up, the parents come to us and complain that most of the times the child is sleepy, he is not taking feeds adequately. So all these babies, definitely an MRI needs to be done. For babies with jaundice needing exchange transfusion, or those who had some or the other feature of bilirubin encephalopathy, again MRI brain needs to be considered at least once. It has to be done. So All this was about the basic postnatal basic care in the high risk clinic, which we need to provide. That we need to first fill out the proforma, we need to check the feeding status, we need to assess the immunization, how is the child otherwise growing, uh, something about the vision, hearing, and a little bit about the blood tests which may need to be done, and also about the neuroimaging if at all it is needed in case to case basis. Now coming to otherwise difficult part, that is the developmental assessment. Sometimes developmental assessment is not so easy, but at least when our residents are sitting in the high risk clinic, there are some screening tools for development which we can use. Okay, so I advise the residents that at least you have the habit of using these screening tools for developmental assessment, and if there is any deviation identified, we can refer them to a special this thing developmental pediatrician, or maybe to an occupational therapist or speech therapist, depending on what area of development is lagging. Okay, so ideally this developmental clinic should have, our developmental clinic or follow-up clinic should have the developmental assessment at this 3, 6, 9, 18, and 24 months. So all the residents make it a point that whenever a child is coming to you in follow-up clinic at 3 months or 6 months or 9 months, uh, take out time and do a little bit of a developmental assessment. It does not need to be done at all the, see, feeding, vaccination, and growth assessment, it has to be done at all the visits. Your vision, hearing assessment, if need be, it has to be cross checked that it has been done or not at all the visits. But your developmental assessment, points during the follow-up time, where minimum 5 times you need to assess the development. Okay, again, for developmental assessment there are certain screening tools and then there are confirmatory tools. The confirmatory tools are a bit difficult and they need training, specialized training. But the screening tools, as the name suggests, they are screening tests, so they can be administered by pediatricians in the clinic. Okay, so at least as resident doctors, I want you to have the habit of using these screening charts. And it is important that we do a regular screening. A single screen may sometimes not be sufficient. So a child comes to you at 3 months, you do a developmental screening and you say, oh, this child is abnormal. May not be correct 100% of the times. You need to have a serial developmental screening again at 6 months, 9 months, 18 months, to see how is the child progressing. And these tests are more useful to identify those areas where the child's development is differing from the same age norms. So one of the screening tools which we can commonly use in our setup is your Trivandrum development screening chart. Okay, I'll show you the chart in the next slide. Looking at the chart, sometimes it may feel very complicated, but it is very easy to interpret and it can be done by all of us. It hardly takes 2 minutes to use that screening chart. And if you identify any deviation, it has to be confirmed by using a Bailey scale for infant development, BSID 4. Unfortunately, at this point of time in our unit, none of us is trained in Bailey scale. So if you identify any child who is having a developmental delay, at least give them the option of consulting a pediatrician, a developmental pediatrician who is trained in this Bailey scale and who can identify exactly how much is the delay, and based on that they can be directed towards an occupational therapist or a physiotherapist or other therapy areas as per the need of the child. Okay, so at least for our setup, I request all the residents to have the habit of using the screening tools. Okay, and one of the screening tools, as I told you, is a Trivandrum screening chart. Okay, and Trivandrum developmental screening chart, there are two charts. One is for 0 to 3 years of age and second is for 3 to 6 years of age. So I have shown here a 0 to 3 months. Okay, 0 to 3 years age. So how to use this chart is, say suppose a child comes to you at 9 months. Okay, so there is a vertical line drawn at 9 months. If you can see here, there is a vertical line that has been drawn. So a child who is coming to you at 9 months, okay, this is as per the corrected age of the child. Okay, whenever you are assessing the development, important to remember is that it has to be done as per the corrected age of the child. So a child who is born at 28 weeks and comes to you your clinic at 16 weeks after the birth, then his corrected age will be only 4 months. Okay, so that time you just need to assess him as per the milestones at 4 months. Okay, but say suppose a child has a corrected age of 10 months and he comes to your clinic at a corrected age of 10 months or 9 months, then what we need to do is that all the items which are, so here is a line which is drawn. Okay, so all the items which are totally to the left of this, so if I see this uh, 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 line, vertical line on 10 months, all the items that are on the left side totally. So if you see from the bottom up to 6, all the items are on the left of this vertical line. Okay, there is the seventh item is crossing 10. Okay, so it is okay if the child has not achieved this seventh item, that is raises self to sitting position, but at least the child should have achieved all these things till the sixth milestone that has been highlighted. Okay, so a child who is coming to you at 10 months, at least he should have uh, achieved this six milestones. Okay, why till six? Because the seventh one is actually crossing the line. I will take into account only those milestones that are totally towards the left of the line which I am interested. So if a child comes to me at say 16 months, so all the milestones which are totally to the left, it should not be crossing this one. So totally to the left is up to 11. So at least a child who presents to my high risk OPD at 16 months, he should be able to walk with help. If he is able to walk with help, I can still say that okay, based on the screening, he doesn't seem to be delayed. Of course, when you evaluate the child in detail, you can put a developmental quotient, you can assess the milestones, you can put a developmental quotient and decide. But this is just a screening tool to identify like if there is any delay or not. Okay, then once you have done a developmental screening, another important thing is neurological examination. So both these topics, that is developmental assessment and neurological examination, both of them are by themselves very vast topics. It is not possible to cover these two topics along with the high risk follow up. But what I have highlighted today is simple things which the residents can do while they are sitting in the high risk OPD. And if you do this, it is going to help you in your practice also at a later point of time. Okay, so in when it comes to neurological assessment, so there are two scales, or there are two school of thoughts for neurological examination. So one is a Hamilton neurological assessment, and second is the Hammersmith. So it, I mean, it is up to us which one to use. So Hamilton, it mainly focuses on the tone, whereas the Hammersmith, it takes into account other areas also, like the behavior of the child and all other aspects. So I mean, it is good if you have time to do a Hammersmith examination. And Amil Thiessen, it can be done on a quick basis. Okay, so because it primarily focuses on the tone of the newborn, and you can, or you should rather use a goniometer for assessing various angles. Okay, so these are the various angles as per the age of the child when they come for follow up. So at 1 to 3 months, what should be the adductor angle? It should be 40 to 80 degrees. If it is less than this, then it shows that there is something abnormal. Between 4 to 6 months, the adductor angle should be 70 to 110 degrees. Between 7 to 9 months, it has to be 100 to 140 degrees. And between 10 to 12 months, it has to be this much. So similarly, all the angles, the common angles which you can see in the newborn on follow up, you should have a practice of screening all these angles. And actually, this type of chart should be pasted in our high risk clinic, because whenever a child comes, you just need to use a goniometer to check the angles, and based on the value you are getting, if this chart is there, you can just see and identify if there is any delay or not. Okay, so this is a goniometer. We have this instrument in our high risk clinic. I had specially ordered and we are having it. Unfortunately, no one is using it right now, but it should be used. Okay, it is very easy to use. It is just like a compass which we were using in our maths classes. Okay, so it is a goniometer. And how to use it, or how to measure the angles? So this is how you use it to measure the angles in the newborn. So you measure this image on the left is measuring the adductor angle, and on the right you are measuring the popliteal angle. So based on the angle which you are getting, you go back to this chart and see whether it is falling in the normal range or not. If it is not falling in the normal range, then it shows that the neurological examination is somewhat abnormal. Okay, and it is good to have the practice of having a Hammersmith neurological examination, but the problem is it has 34 items. And if you sit and do a neurological examination, it is going to take some time. However, a resident who is posted in the high risk clinic, he has good amount of time there. So it is desirable that you take out time and you examine all the 34 items, and many of the times it is self-explanatory. It does not need much of a training. It has a figure next to each item, how to do it. You do it and plot it, and then you find out how much is the score. Ideally it has to be done at 36 to 40 weeks of corrected age. Again, I think it is difficult to cover this neurological examination part in today's talk. Maybe we can have a separate class for the neurological examination, both Hammersmith and Amel Thiessen angles. Okay, but the point is that it has to be done. And then coming to the last part of the talk, that we have examined the child fully. Now, how do you decide when to call them next for follow-up? Okay, we have based on the risk stratification, we have divided them into a yellow category or a green category or a red category. Now, how often to call them for follow-up? So I mean, this can be unit specific. In our unit, I have formulated this guideline that what should be the schedule for follow-up visits based on the risk stratification. So if a child is falling into the green zone, that is, there are no red flag or yellow risk factors. Only the child is admitted, say, for a simple jaundice needing phototherapy, bilirubin was 18 or 19, needed phototherapy for a day, or a child was just admitted for simple O2 therapy, in otherwise healthy child, no sepsis, no antibiotics required, anything, then that child falls into the green zone. And that otherwise well child, it is okay if you don't call them for follow up every week, but at least these 5 visits have to be done. Okay, so as you can read here, at least 5 follow up visits have to be done. When those 5 follow up visits have to be done, first at 1 week, second follow up visit at 3 months, 6 months, 9 months, and then at 18 months of corrected age. Okay, so a child who is admitted to a high risk clinic for a simple jaundice, you need not call them for follow up at each vaccination or at each week or month. Okay, but at least you tell them that they can have a follow up and vaccination in their nearby CHC or at a nearby pediatrician. Okay, because someone who is coming from Samakhyali or Bachau will not want to come for a simple checkup, that too for a otherwise healthy child. But you tell them that at least 5 visits they have to pay to us at 1 week, and then at 3, 6, 9, and 18 months. Okay, so this is the minimum schedule you can ask them to have. And when they come for 3 months, 6, 9, and 18 months, you do a quick developmental assessment as well as a quick neurological examination just to make sure that the child is otherwise healthy. Okay, and you may advise 3 more visits if there is any ongoing illness or issues. For a baby who is falling into the yellow zone, so into the medium risk category or yellow zone, for low risk, we told at least 5 visits. For yellow zone, at least 8 visits. First visit again being at around 1 week after discharge from the hospital. Then subsequent visits at 6, 10, 14 weeks when they're coming for immunization. You call them for a follow-up visit, okay, at the same time as immunization, and that time you just assess whether the child is growing properly, weight gain is adequate or not, and there any other issues which are coming up subsequently. Okay, and vision, hearing screening, whether everything has been done or not. Okay, and then you call them for a subsequent follow-up at 6, 9, 12, and 18 months of corrected age. More visits again they can be done if there is any ongoing illness. Okay, and lastly, for babies who are falling into the red zone, at least 12 follow-up visits. So these are high-risk babies. They need to be followed up very frequently. So first visit has to be at 3 days, within 3 days after the discharge from the hospital. Then you ask them to come at least every 15 days once, or every 14 days you ask them to come once till the child reaches a weight of 3 kgs, because these are all your VLBW, ELBW babies who have stayed in your NICU for a very long time. They're expected to have some or the other developmental problem. So you ask them to come for follow-up at least till for every 15 days till the child reaches a weight of 3 kgs. And then subsequently you may ask them to come at 6, 9, 12, 15, and 18 months of corrected age, and at these later dates you can do a developmental assessment. So I think this is it from my side. If there are any questions, I will be happy to answer. The whole point of today's talk was that at least you start doing this high risk follow up properly. Once you are more into it, you will have your doubts. We are there to solve you. We definitely need to improve a lot in our high risk clinic, but have have the habit of sitting with the child and identifying the problems the child has. Okay, only then, because if you see the patients properly, only then they will have the motivation to come for a follow up. Otherwise, if we just see them in 2 minutes and tell them कुछ नहीं है सब ठीक है, then next time they will not turn up for a follow, because they will tell अरे डॉक्टर तो कुछ देखते ही नहीं है उधर, तो कुछ नहीं, सिर्फ वजन चेक करके वापस भेज देते हैं. Okay, so sit with them, talk to them, what are the problems they are facing, whether the child has adjusted properly at home, any developmental problems, or if you are able to make out, you tell any of the consultants available. Okay, and we'll also in the coming few days or months, we'll try to make sure that at least more consultants from us are available in the high risk OPD. I think if there are any other questions, you can ask.
Thank you so much, Dr. Sandeep. It is really a wonderful lecture, and all the residents definitely get the benefit from this.
જે ન્યુરો ડેવલપમેન્ટ અસેસમેન્ટના ટૂલ્સની જે વાત કરી છે એની ઉપર થોડું ડિટેલમાં જો વિડીયો આગળ ક્યારે મળી રહી ને.
Definitely we can plan a session developmental assessment ઉપર, but again the thing is that many of the times શું છે કે there are many different questionnaires, something like MChat for autism. Then there is one ages and stages questionnaire. It is a simple questionnaire which you can give to the parents, and they just have to simply tick કે ભાઈ ચાઇલ્ડ આવું કરી શકે છે, પેલું કરી શકે છે, યસ યસ યસ, તો ઠીક છે, તો એના બેસિસ પર તમે કરી શકો. One such simple screening tool is your Trivandrum development screening chart, है ना? तो at least the point is कि you start using it. हाँ, I mean if you want we can plan a separate session on it, developmental assessment માટે, है ना? But the thing is that I mean at this point, see જે એના complicated or parts છે, like Bailey scale. So ideal જે છે developmental assessment should be done using a Bailey scale. Bailey's is now considered the gold standard, and Bailey's ma bhi now we are having Bailey's 4, which has come, say I think in 2022. Bailey's 4 has come. So that is the recent thing which many of the developmental pediatricians are using. Okay, but developmental assessment mate gold standard je Bailey's che, it needs specialized training. Okay, so you and me at in our clinic we cannot do, because any mate you need some developmental tools also. You need to have cubes and other play items, toys, and then certain other things, okay, to test it. And also you need to have a person who is specially trained for it. But at least when you are sitting in your high risk OPD, you should at least have this screening chart with you. Once you screen, you find something abnormal, at least you give the parents an option of going to a developmental pediatrician. Or even if they are not able to go to a developmental pediatrician, at least you teach the parents some early intervention, this thing, what can be done, like a simple physiotherapy at home, simple hearing and vision stimulation at home. Okay, so all those things can be done so that they have a better outcome, right?
Okay, thank you.
Raju, if you simply follow the simple developmental milestone, if you remember the developmental milestone which child achieve according to the chronological age, then also you can simply screen the baby for the development. And for neurological assessment, already I have uploaded a video on Hamilton cell, and it is very easy to understand. I will share in the group also. So both the development as well as the neurological assessment should be done in the follow-up visit. We are taking care of the vision, hearing, immunization, everything. But neurological and developmental assessment of each and every baby should be done in the high-risk newborn clinic. So today's talk is really very useful for all the residents, and hope next time they will follow all the instructions given by the Dr. Sandeep. Thank you so much, Dr. Sandeep.